Hi, my name is Kathy Howes, physical therapist and transitional DPT student at UNC. The title of this project is Constraint Induced Movement Therapy and Bimanual Intensive Therapy for Children with Hemiplegic Cerebral Palsy. Please take a few minutes to complete the pretest associated with this teaching unit. There are 12 multiple choice and true-false questions. After viewing this presentation, you will be asked to take a post-test as well. Please review the learning objectives for this teaching unit on the next two slides prior to proceeding. The prevalence of perinatal stroke in the United States is estimated at 6.2 per 100,000 live births. Perinatal arterial ischemic stroke is the most common form of stroke in children. Stroke can occur before birth in infants, children, and young adults, but the risk is highest in the first year of life and peaks during the perinatal period. The picture illustrates an MRI of a right ischemic stroke. "35% of the cerebral palsy population has hemiplegic cerebral palsy. Children with hemiplegic cerebral palsy exhibit incomplete paralysis on one side of their body. Typically, the upper extremity is more involved than the lower extremity. The International Classification of Functioning Disability and Health, or ICF model, is the World Health Organization framework for measuring health and disability at both individual and population levels. This presentation will apply the ICF framework to describe how hemiplegic cerebral palsy affects body functions in structure, activity, and participation. Increasing activity and participation through a constraint camp model will be discussed later in the presentation. The young man pictured is exhibiting limitations in all three areas listed on the slide. This includes an elbow flexion contracture, inability to grasp secondary to spasticity, and poor grasp strength. Additionally, note his poor body posture and head alignment. Visual deficits in children with hemiplegic cerebral palsy might include hemianopsia and visual neglect, as well as oral motor problems and delays in acquisition of functional bimanual tasks. Children with hemiplegic cerebral palsy may display hypersensitivity or hyposensitivity to touch. Additionally, they may exhibit tactile defensiveness or impaired discrimination. Their proprioception may be impaired, altering body image, posture, and midline orientation. Learned non-use is a term that refers to the phenomenon in adults post-stroke that have repeated unsuccessful efforts with voluntary movement leading them to not use the involved upper limb. Learned non-use was described by Taub and colleagues. In his primate model, the deafferented animal is able to operate in its environment successfully using its other limbs and is thereby rewarded for this compensatory pattern of behavior. When the motor neurons spontaneously return to a state of sufficient excitability and the animal recovers the ability to control movements of his deafferented limb, the animal continues to avoid using the deafferented limb because of his learned history. Of most relevance to physical rehabilitation, research demonstrated that learned non-use of a deafferented extremity can be overcome permanently by restricting movement of the intact limb for an extended period. Developmental disregard is a term coined by DeLuca to describe a child with hemiparesis who neglects the involved upper limb as if the limb is not there. As a child uses the weaker upper limb and has difficulty, he tends to adopt using the less involved upper limb because it is more successful. The child continues using a unimanual approach with the uninvolved upper limb while decreasing attempts at using the impaired upper limb. In the early 90s, Dr. Ed Taub and colleagues applied an animal model to upper limb rehabilitation. Next, human interventions, including forced use in adult stroke patients in which the less affected upper limb was physically restrained to passively induce practice of the more affected upper limb. Subsequent attempts incorporated principles of behavioral psychology, including shaping and motor learning, to elicit active practice of the affected upper limb. These efforts have evolved into constraint-induced movement therapy, or CIMT, and later use of CIMT with children began in the early 2000s. Classic CIMT involves placing a full-arm cast or constraint mitt on the unimpaired upper limb for 90% of waking hours for 14 consecutive days, accompanied by intensive training for 6 hours each day. This protocol was later modified to involve restraint of the unimpaired upper limb, with variations in the type of restraint applied, and are accompanied by repetitive manual task practice. Modified constraint departs from constraint in terms of the model of therapy delivery. It involves a decreased intensity of shorter duration with fewer hours of practice. In the mid-2000s, a paradigm shift occurred as Charles and Gordon introduced another intervention known as hand-arm bimanual intensive training, HABIT, or BIT, after they identified bimanual coordination difficulties in children with hemiplegic cerebral palsy. This intervention involves extensive targeted practice provided in a child-friendly manner without using a physical constraint on the involved upper limb. Activities requiring bimanual coordination are then practiced through play, dressing, and activities of daily living. Please take a moment to read the PICO question, which drives this presentation. This is an important clinical question as children with hemiplegic cerebral palsy exhibit functional limitations secondary to impaired bimanual coordination in addition to their unilateral impairments. The most efficacious treatment intervention for children with hemiplegic cerebral palsy has not been clearly established. This information will provide guidance for therapists and caregivers of children with hemiplegic CP for appropriate and effective clinical treatments to improve impaired upper limb function. For this project, 8 randomized controlled trials, 3 systematic reviews, and 1 meta-analysis comparing CIMT and BIT for pediatric patients with hemiplegic cerebral palsy were reviewed. Please see the listed references for the specific articles reviewed. Subjects' hand severity was determined by the Manual Ability Classification System, or MACS. It classifies how children with cerebral palsy use their hands when handling objects in daily activities. The system defines 5 levels of hand function. The classification is designed to reflect the child's typical manual performance, not the child's maximal capacity. It classifies the collaborative use of both hands together. In the studies reviewed, the children's hand severity ranged from a max 1 to a max 3. The most commonly used outcome measures in the literature comparing CIMT to BIT include the Assisting Hand Assessment, the Melbourne Assessment of Unilateral Upper Limb Function, and the Jepson-Taylor Test of Hand Function. Please see the Outcome Measures table for more information on all outcome measures used in the CIMT and BIT research reviewed. Additional outcome measures used in the literature to compare CIMT and BIT in the literature included the Pediatric Evaluation of Disability Inventory, the Canadian Occupational Performance Measure, the BESTA scale, and the Quality of Upper Extremity Skills Test. Again, these outcome measures are described in more detail in the Outcome Measures table. I will now discuss treatment protocols used in the various studies. Treatment interventions in the reviewed studies range from 3 to 6 hours per day for a total of 50 to 210 hours total and was performed between 10 days to 4 weeks. It should be noted that the optimal dosage for either intervention is still not known or agreed upon. Results from the reviewed studies demonstrate that both CIMT and BIT lead to similar improvements in upper limb function of the involved upper limb. Both interventions showed greater functional outcomes and improvement than traditional treatment. It should be noted that traditional treatment was not well defined or described in these studies. The traditional treatment group received much less intervention time compared to either the CIMT or BIT treatment groups. The improvements from either CIMT or BIT intervention lasts from 26 to 52 weeks following intervention and are retained with no further intervention provided. Brain reorganization has been determined to occur with the use of CIMT, although no studies are yet reported for BIT. Rowe et al., using transcranial magnetic stimulation, showed cortical reorganization and accelerated motor recovery following CIMT interventions in adults who had had strokes. Sutcliffe demonstrated cortical reorganization in children with hemiplegic cerebral palsy following CIMT treatment. Functional MRI showed increased contralateral cortical activity, and the cortical reorganization was maintained at 6 months follow-up. A more recent study by Sterling et al. Demonstrated that CIMT in children with hemiplegic CP is associated with structural remodeling of the brain, specifically increasing gray matter. Choice of intervention may be based on expected outcomes. CIMT has been shown to be better at improving unimanual performance, while BIT is better at improving bimanual coordination and bimanual performance. It's not about the cast. All studies reveal that practice and intensity may be the key ingredients to improved outcomes. Specificity of training demonstrated more improvement in task practice such that CIMT improved unimanual capacity and BIT improved bimanual capacity. In conclusion, the existing evidence demonstrates that both CIMT and BIT improve upper limb function in children with hemiplegic cerebral palsy. The intervention chosen may depend on the expected goals and outcomes to be achieved. Several reliable and valid outcome measures are available to measure improvements with either intervention. Both CIMT and BIT interventions offer therapists powerful tools in our toolbox to make lasting changes in a child's upper limb functional abilities. Please take a minute to read the next 2 slides, which summarize key concepts related to this literature review. Several clinically relevant points can be extracted from this literature review. Both CIMT and BIT improve functional outcomes in upper limb function in children with hemiplegic cerebral palsy, with neither technique being superior to the other. Longer-term studies have shown that the improvements from either intervention last from 26 to 52 weeks following the intervention and are attained with no further intervention provided. Brain imaging studies are demonstrating neuroplastic changes such as increased contralateral activity and cortical reorganization. Helping Kids with Hemiplegia is a constraint movement camp that integrates CIMT and BIT into a camp environment. The information learned previously can be applied during this camp experience. The camp is 6 hours per day for 10 consecutive days. Each child with hemiplegic CP will have a one-on-one PT or OT student who will assist the child throughout the day. The camp is founded and directed by Holly Holland, OT, at UNC Hospitals. Who can provide CIMT or BIT interventions? You can. Research has demonstrated that these interventions don't need to be provided by an OT or PT to be effective. It can also be performed effectively in a camp setting. You will be practicing evidence-based medicine by participating in this camp. The intensity will be 6 hours per day for 10 consecutive days. You'll be using interventions green-lighted in the literature as effective at improving motor outcomes for children with hemiplegic CP. You'll also be enhancing activity and participation in these children. You will be assisting children with hemiplegic cerebral palsy with functional tasks and activities of daily living, such as dressing, shoe tying, and eating, providing both unimanual and bimanual practice. Prior to donning the cast, range of motion and sensory input will be performed. Children will work on various fine motor tasks with no limit to your creativity to help children achieve the goal. Bimanual play and functional tasks will be emphasized when the child is out of their cast. You will participate in shaping. Shaping involves progressively increasing the difficulty of tasks as the performance of the child improves while providing immediate, encouraging feedback when the child makes even small gains. You will assist the child in practicing specific movements and tasks that you may want to improve, such as supination in this example. Reach may be another task that you're practicing so that you practice using the whole involved upper limb. Working on grasp with children with hemiplegic cerebral palsy may be another task to target. Learning to release after grasping an object is another important functional goal for children with hemiplegic cerebral palsy. Children will learn and receive many repetitions of practice through various play. Please note that all children and volunteers represented in this presentation have signed photographic releases for their images to be used. I hope this PowerPoint has been informative and assisted you in learning about CIMT and BIT and will enhance your camp experience. Please take a moment now to complete the post-test for this unit. The correct answers will be listed on the next slide. Thank you for your time and attention. Realize you are a huge reason that camp will be successful and that you are positively impacting the life of a child with hemiplegic cerebral palsy. We'll see you at camp.